Welcome everyone. Thanks for joining us at this very early session. I'm not talking now, I'm simply calling on stage Salvo Leone, IFCCA President, and Professor Magro from ECCO. Please join us.
Good morning, everyone. Good morning, Fernando, for joining. Well, we are living in a very particular era. This morning I was thinking that I'm the chairman of IFCCA since 2018, and I joined IFCCA, now IFCCA, in 2003. From then, the world has changed. I mean, we think in a different way, we approach in a different way. We have several tools to treat the disease. But still, the unmet needs of patients are the same, and also we don't know where to put the patient voice. At the beginning of this Congress, at the end of the decision making, we know that we don't want to be more than the doctors. We don't want to select the therapies telling the doctor what to do. But we know for sure that the patient experience at a certain moment is important, is complementary to the process of cure, and is also important. So that's why the scientific part is on the hand of the doctors, and the patient experience is also important. That's why today we are opening this session with a very important moment, because we are going to discuss the role of patient in the health technology assessment area. So we want to put the patient perspective at the center of the value assessment. We are entering in this new phase of HTA in Europe, and in this context, the decisions are becoming more structured than 25 years ago, more demanding and more evidence-driven. I mean, we know that is very difficult. We know that the doctors are becoming more and more precise, but this is a critical moment for every patient. Why it's important, the value of the patient perspective? Because health technology assessment evaluate, it's evaluate value, but the value is defined by real life experience. The efficacy of a drug is 10% clinic, and at the hospital we are becoming excellent. 30% is genetic, we don't track anything about genetic, and 60% is what the patient do between visits. 60%. That means that once the patient is visited at the hospital, until next visit, we don't track anything. It's probably the artificial intelligence will help us on this, but this is important. Patient experience outcomes beyond clinical endpoints. This is why their input is essential to ensure comprehensive decision makings. So from experience to structure contribution. So here we are with the DIVA. Patient input must be measurable and comparable. This is where methodology matters. And this is where DIVA come in. I mean, this is our tool to make live experience visible and usable for HTA. So we don't want to collect story, but we want to give a tool to doctors to better understand what is experience between visit, to give them a more powerful tool to better understand, to better support patient, and to better decide what is the best strategy. United, we can put patient at the center. And when I say united, I don't want to leave outside of this process of pharma industry, because we have the clinician, we have the patient community, we have the decision makers, but also we have the pharma industry. They are working to create better drugs for patients. So the more precise we want to be, we want to involve all these stakeholders around the table. Together we can make HTA reflect not only data, but live the realities of people with diabetes. So that's why I thank you for being here today. I know it's very early. It was early also for us. I thank you so much, our friends, Professor Magro, for opening this important event for us. And I give you the floor, Fernando. Thank
you. For me, a great pleasure to be here and to be here with the President of IFCCA. Now IFCCA. So for us, ECCO, and I'm speaking on behalf ECCO governing board, it is a unique opportunity to communicate with the patients. And it is very important for us to have the feedback of patients, how the patient think about the disease, what the patient indeed feel. So a close relationship between patients and doctors and patients' organizations and doctors' organizations, it is for us very important. And it is for us a priority. So we met in Berlin last year, in Stockholm now, and a big thank you for you, because you are also help us in ECCO school with a grant. And ECCO has a rich strategy. And this year is H. What does it mean? Is a holistic approach. And holistic approach center in patients. It is the first sentence. Center in patients. But also in strategy, and a strategy must to be common between doctors and patients, and a common treatment. And this year, the ECCO lecture will be on Saturday. It is about gut-brain axis in hygiene. So important for us is this crosstalk between gut and brain. And please check out our exhibition dedicated this year to holistic approach. And please also go to nurse guide poster session, and this poster session will be tomorrow on Friday between 12:40 until 30. It is very important to have the patient perspective, looking the poster, looking the science, the way of we are doing science. And now we have a new journal. It's a JCC+. We have the JCC to spread knowledge, science, and communication of science. But now we have JCC+. It's an open access journal. And we pretend with this journal that it will be a broad scope, and for us it is very important to be a voice for the multidisciplinary team, including patients, of course. It is our aim, and our aim integrated in this reach. It is my last slide, and indeed it is a huge pleasure to be here, and warm welcome you. Thank you for coming.
Fernando, and let's welcome together our CEO Luisa Vedano for opening the session. Thank you so much.
Good morning, everyone, and thanks for coming. As Salvo was already saying, it's an early session, but we hope that we can raise some interest on this topic that is not the most easy and manageable one, but for us it's very, very important. My task today is to give you a very quick overview on what we are doing and how we are approaching the HTA topic from the patient perspective, of course, and I will just give you some general ideas, and then the next presentations will be more in depth on the different aspects of the HTA framework. There are a lot of boxes and a lot of descriptions. I'm not gonna explain everything, but the presentation will be then made available on our website. But what I want to, for instance, on this slide highlight is the role that patients can play on the joint clinical assessment and the joint scientific consultations. We are entering in a new era where the role of patients is getting more and more important and central. It's a requirement, so it's not just because we want to have a voice, but it's because the European Commission, the regulators are asking loudly our opinion, but there is a but. We need to be prepared, and I hope that during the other presentation and the debate, we will be able also to better understand in which way patient and patient association can really join forces and work together in order to achieve a solid bunch of information that will give us the real voice when it comes to taking decision and choosing the right treatment. So coming back to these boxes, the joint clinical assessment has not changed. So it's the same mechanism, it's the same procedure that has been already in place when it comes to the assessment of the collection of information. But this is important because in this way we can collect more information for the future. When it comes to the scientific consultation, this is where we are planning for the future, and you will see in the next slide that patients can play an important role. Basically, what we need to do is to identify the most promising technologies, devices that generate information, and identify where are the lacking points, like preventive measures, advanced therapies, that really can change the way we assess risk and benefit. Just to give you an example, think about the big success and the publication of this case that was published on the New English Journal of Medicine regarding the UC patient that was successfully treated with the drug that has been used for cancer, so the CAR T-cell therapy. So, there is a word that we need to explore. It's something that we need to better understand, to collect more information, and to be prepared for the future steps. I just wanted to mention that when it comes to the HTA stakeholder network, we are participating in all the consultations that are launched by the European Medicine Agency, and recently we have been contacting and we are talking to them because we are applying to become part of the list of partners that will be permanent, the network of the European Medicine Agency, that we will be part of this permanent group that will be consulted in different activities but EMA, and I think it's another important proof of the way we are working and the solidity of the information that we are putting at disposal. This is again in a nutshell what we are talking about the domain, you see, and which are the players. From one side we have the European level, and from the other side we have the national level, and we are supposed to work in a way that we are feeding each other without creating any contradictions. When it comes to the domains, you see, from one side we have the clinical domains that are, for many of us we are more familiar to them, and on the other side we have the clinical domains. We put a question mark asking at the same time, because this is not still very clear, but we thought that the two blocks should be assessed together, because if we have first the assessment of the drug and then we realize that, for instance, from the organizational point of view there is a difficulty, we are stuck, and this means that patients will not get the drug that has been positively assessed because of some blockages. As visually you can see the role we can play as patients in the circle in the process of JCA, the Joint Clinical Assessment, You can see two big blocks in which patients play a role. One is the scoping process, that is a quite new approach that is also changing a lot the way that as IFCCA, including our colleagues and patients that are involved in our focus groups, in our activities in the European project, etc., are applying. I mean, for those who are not very much familiar, this approach has a bottom-up way of working, and this is also why we are working a lot with our members to make them part of this process, and collect from the National Association the initial feedback. And this is the most sensitive and important aspect of my presentation that will be then presented in other parts. This is crucial for us, and this is why IFCCA is working a lot on DIVA and is working a lot on the methodology of collecting the information. I will come to that later, because we can't do it alone. We really need to collect and information that are really accurate, and for doing that we need to be aligned, we need to put together the subgroups, and we need to work together in order to create a basis of information that can really then be useful for the next steps. So, as you can see, it's a huge responsibility. We are working on this tool because we believe it's important to join forces, but we are still at an early stage and we need to increase the level of collaboration among all of us. The other step in which patients are involved is the assessment phase. I'm not going to read all of this, I will be very quick. You will see that we have several red words. These are the parts where patients are supposed to participate in the PICO part and in the assessment part. You will see that the third one and the seventh one is on scoping, the other one is on assessment, are mandatory. It means that patients have to intervene in revising the reports and having a say, but look at the numbers, we only have 7 days to do that. It means that if we are not prepared at the very beginning, if we don't have the information that can be required, we will never be able to have a consistent set of reactions and print reports as we are supposed to do. And this again, it's a warning, is a message for everyone. We need really to be prepared, because now we have also the opportunity to learn from the first condition that is now working on HTA, that is cancer, but we need to start now in collecting and being informed about our condition, our subgroups, etc. So, in a nutshell, the JCA offers an extensive participation of patients, as you saw in the big plan. But, as I was mentioning, it implicates an extensive preparation of patient and patient associations. We can't run the risk that, for instance, at national level, there are still the pending issues, because then we also need to work with the developers, so the industry, to put together all the information and having the complete picture. And the challenge is very clear for patients, because we need, and this is something that Roberto will explain later in his presentation, as patients we need to know who we are, what is really happening to us, which are the available treatments, but also which are our expected outcomes and what for us is missing and why. So in this context, you know that participation has a completely different declination. It's not just sitting and having a say from our individual perspective, but having a bunch of information that allows us really to have a say, a solid and evidence-based say. Now briefly, let me introduce DIVA. DIVA stands for, it's something I just wanted to tell you a story. We were trying to find a name that was appealing, but also with a meaning. So after a certain number of attempts, we found that DIVA was the right name. DIVA stands for Data Insights for Added Therapeutic Value. So finally, because we are talking about DIVA, but nobody knows what it means. And for us, it's a very important step in our history. It addresses the challenging and the lack of clarity from every stakeholder. And it's a tool that we have been starting developing nearly 3 years ago. Probably some of you were 2 years ago participating in our another ECCO meeting where we have been presenting the early stage with DIVA, and now we are here presenting what we have been developing. So DIVA is a data-driven methodology, and the main point, and please connect the dot on what I was saying earlier about the HTA framework, it gives us the opportunity to not only collect the data, but to develop it, turning them into a clear evidence that can help us in developing patient-centered healthcare solutions. So DIVA allows us to translate complexity into insight, the eye of DIVA, that makes sense for everyone. It's a multilingual platform. It merges, and this again is another very fascinating aspect. It merges public data, those who are publicly available, like on PubMed, the surveys, the documentation, the article published, and the survey and the analysis that are published, so they are publicly available, with, and this is the crucial point, patient testimonies across countries. That means that we are interviewing patients, collecting them, and then Roberto will explain you more, the artificial intelligence works on this information. And the purpose is to provide a full picture of each condition before new drugs are developed. So you see, we have our members, the IBD associations, are sharing patient testimonials. Artificial intelligence classifies them by disease, sex, all the categories. And the final step, and that is really the most fascinating aspect, the artificial intelligence compare this information with the published literature and identify the gaps for future research. So, in this way, the real patient experiences are collected in a continuously updated database and analyzed with artificial intelligence. And for doing that, we follow a European quality standard that is the UNETA framework. And again, I'm not reading all the questions, but this is the structure through which we are interviewing our people. And in this way, we are able to collect meaningful insights from patients, enabling us to provide coherent evidence-based data. So, the value of DIVA, and this is why we are really proud of the evolution that we are seeing on DIVA, is that we are able to provide our stakeholders with solid answers that are grounded on real patient experience. And I think that the majority of you saw them because we published them on our website and our social media. We are able to produce final reports in any language, so even the information can be translated in any language, and so we are able to enable effective work at both Europe and national level. You will see later in one of our presentations from a panelist that we are not only working in Europe, we are already applying DIVA in other parts of the world. So for us, it's crucial, and I'm closing here. This is our take-home message for the day. Understanding patients starts with listening to our communities. And we want to ensure meaningful patient information and serve as a key advocate for patient priorities. Thank you. Now I'm giving the floor to Dr. Tara Sharma, did I pronounce well? Yes. She's the technical officer, but you can tell more, it's also in the program. She's working at WHO Region Europe, and she will give us a more technical overview of the HTA framework.
Thank you everybody, and good morning, and also thank you very much for the invitation, Tivka, for coming and speaking to you all. I really feel a guest amongst you all, and I think it's really a privilege to see the hard work you have been doing, and I have to say you are ahead because many other conditions are now just trying to understand the potential you have now to be really able to inform decision making in Europe as really key partners in the process. So as Luisa mentioned, I'm a technical officer working in the WHO Office for Europe, focusing on novel medicines and bringing new innovative treatments, and the lead for HTA as well. So I thought I would start with going a little bit back to see where we are. So Europe, in our office is, I'm not going to get into the details, but it covers a broader range of countries than, say, the EU HDR regulation that Louisa mentioned. We have 53 member states, all of Europe, all the candidate accession countries, Central Asia. So we are broader, like IFCCA is global as well. And we have different technical centers, and one of those technical centers is based in Athens in Greece, and it's focused on quality of care and patient safety. And I work very closely with them because they really have HDA as the heart of their work as well. And of course, as we know, the life cycle of medicines is broad, so this is what my unit covers. It's access to medicines and health products, but we support all parts from development, R&D, manufacturing, registration, and this is where I'm going to talk a little bit about selection, pricing and reimbursement, which is where health technology assessment sits within the WHO. And we really do believe in partnerships and working with industry and promoting innovation, because we do want new treatments for you all, but it has to be the right ones and good for health and well-being. So I want to take a step back so that everybody understands what we are trying to do. At WHO, our main purpose for health technology assessment is really a tool for universal health coverage. We want to make sure that all patients have access to all the treatments and services they need without getting into poverty, so that there is a net, there's a safety net, and which we all understand very well. In Europe, having a social system so that the governments can actually provide the care you need without having extra charges or out-of-payment pockets for you as patients. The world of sort of HTA came into WHO not really that long ago, considering it's been around since the 90s. It came through a resolution at the World Health Assembly in 2014, where member states then asked WHO to start supporting countries to use this as a tool in support of universal health coverage, because we really do see it as a mechanism to providing care for all. And that's sort of when we started the work formally. And this is just for you all to know, there is a really nice database which has information about health technology assessment, and apologies for the acronym. HPV stands for Health Benefit Packages, so this is what is reimbursed by countries. And you can look at the different regions, you can look at the different domains, and one of them is in stakeholder, for HTA, one of the main domains is also stakeholder engagement. So you can go, drop down, it's a dashboard, you can look at your country, you can see what kind of processes for HTA they have, and whether they are following these domains, including stakeholder engagement. And just to say, you can also look at country profiles and play with the data as you see fit. So this can actually help you complement and understand the world you're working in the specific country and the regulations. That said, this database is old. It's from, the last round of data is from 21. They are planning to do one for 26-27, so hopefully you will have newer data by the end of next year. So this is just a background, really, and I have worked also for Cochrane for many years. For those of you know, it's a sort of also a global organization, but of evidence, and it really collects evidence, and I think it would be great for you all also to partner with them, because they do elevate patient evidence at the same level as all other clinical evidence. But I really like this cartoon because it really shows where we are. So EMA, or the European Medicines Agency in Europe, looks at safety and efficacy. That's what they're mandated to do. They need to just see, does it work? Is it safe? That's efficacy. But actually what HTA does is the next two levels. So it looks at clinical effectiveness and at the national level, cost effectiveness as well, where it determines, is it really the best option out there amongst the different things available? And then at the national level, the cost effectiveness, is it really good value for money? Is it what we want? Is it the best use of our resources? Which
unfortunately all governments have to still consider, because there is a finite budget and they have to make sure they're allocating their resources in the best way possible. So I want to talk a little bit about the EU now and the HTR that Louisa mentioned, and I'm going to try not to complement but not to repeat. So this is sort of what I've set up the regulation system looks like now, and I'm a methodologist. I'm not a clinical person and I'm not a patient. I'm an epidemiologist. And that is actually what is sitting in most of the regulators at the national level and at the EU level. So you have the European Medicines Agency, which is your regulator. They're looking at the efficacy part of it. And now we do have the coordination group of the HTA, which has got a big remit, I would say. And they are looking at horizon scanning, what's coming, what's new of interest. And that is voluntary still, but there is an annual report that the Emerging Health Technologies subgroup, the wonderful diagram that Louisa shared earlier shows. They are trying to look and see what's coming in the future that will actually have a real impact for health of patients or for health systems in general, but that's still voluntary. The joint scientific consultations and the joint clinical assessment, this is mandatory, and so this is now all countries are doing this part together. Scientific advice, which is powerful, really, this is what kind of evidence should be making the package for submission. And they can do this in parallel, so in combination with EMA. So you're doing the scientific advice both for the regulator and the HTA together, or you can do it with only all the HTA bodies and get a joint opinion for industry to say, this is the kind of data we are interested in. And so again, looking at DIVA, this is where you really can have a huge impact as well. And then, of course, the joint clinical assessment, which is where Louisa showed you where you can actually have, as patients, an input at the PICO level, at the assessment level, which is PICO is the population intervention, comparator, and outcomes. This is the scope, this is the questions of real value and interest. So this is really where patients have a massive role to play to tell countries and then industry what are they interested in looking at and what is of value. And then the actual, once the assessment is done by the agency. So the way it's working is you have, for each individual assessment, 2 agencies that are doing this assessment on behalf of all the other European agencies. You have a lead and a co-lead, and then they have to follow the methods and procedures of the European level, which are aligned with the UNETACO model, which was the voluntary project that sort of brought the regulation to life, that Louisa also mentioned from the work that DIVA is doing, is aligned with that. So these are certain domains and areas that they look at. That said, then the actual cost effectiveness and the national appraisal, so the actual putting it all together across the clinical and non-clinical domains, that work and decision and reimbursement is happening at the national HTA agency. And then in Europe, most countries also have a payer or an actual reimbursement procurement agency. And that is at the moment happening at a voluntary level. There is a management group of NCAPRA that was also established only about a year and a half ago now. Before NCAPRA met informally, but now probably 3 years ago they formalized it, and now there's a management group that is sort of in a way similar to the coordination group, but not legally mandated, where they're doing these discussions also at a European level. So now you are really doing a lot of things together. And I think, to be fair, collectively you do have more power and more say. And again, at the moment they don't have a formal patient voice in NCAPRA, but they do have sometimes stakeholders that they are inviting. And then the clinical guidelines are done afterwards, and that's at the national level, and then equality care indicators are also done at the national level. So we are talking about a small part of a long chain of events that need to happen from sort of literally the lab and a product being in the market to actually bedside to you having it as patients. So just to say, the scope is not there for Crohn's or ulcerative colitis yet. We are looking at cancer and advanced medicinal therapeutic products, or ATMPs, for the first 3 years. Often medicine products will start in 28 for the implementation. That said, of course, some ATMPs are also fitting that, or oncology medicines are also fitting that category, but they are in there for their type. And then from 2030, all treatments will be in that. And there you really need to be ready for it. To say also from 2026 from now, selection of high-risk medical devices and in vitro diagnostic medical devices is also in scope. So if there's things that you need in terms of colonoscopies or whatever new digital tools that are coming that already apply to you today, they will already start the process from this year. And as I mentioned, that there's also the joint scientific consultations apart from the actual HTA or clinical assessment, which can happen in parallel or with the medicines agencies as well as expert panels of the devices. And this is again a really huge opportunity for patients to really influence what kind of evidence is then submitted and decisions are then made on. And as I mentioned, there's horizon scanning methodology, and there's also methodology for joint work for other voluntary areas. So if some countries within the region want to say, well, actually, we'd like to do the cost effectiveness together, they can voluntarily apply and do it together. At the moment, they have so much on their plate, so that has not yet happened. So I think Louisa shared this as well, so I'm not going to spend too much time on it. But the HTA domains that are being done jointly at the EU level are the clinical domains, the health problem, the current technologies, description, the relative clinical effectiveness, and relative safety. And all the other aspects, based on also originally from the UNETICO model, the economic evaluation, ethical aspects, organizational aspects, social aspects, and legal aspects are actually being done at the national level. And I think this is very, very important because a lot of the patient broader perspectives of impact, the formal quality of life and the formal data as you collect it from DIVA will then become formal clinical evidence, but the understanding and some general broad testimonials or what you bring to the table, how it works in your own context in the countries you are, will happen at the national level. So you do still need to have a very strong voice as patients at the national level, and then at the EU level you can bring the formalized data together. So I'm not going to spend this because this lovely chart has already been shared by Louisa, but I just want to say the stakeholder organizations really has a significant amount of patients in there. They're 36%, and then there's payers, professional societies, industry, and actual healthcare professional associations as well, and other civil society NGOs. So the patients are a significant chunk of the stakeholder network that actually review and comment on everything before it becomes finalized at the EU level. So this has changed now, there's 14 going on, and there are 15 countries involved in this, and then there are more than 50 patients and carers, as well as clinicians across the different countries. So you are really getting a geographical spread for these now 14, 13 at the time of this graph. Patients and carers are coming from across along with clinicians. So at the moment, I don't have the data, I'm going to ask the Commission for the split. But just so you know that through the regulation and the way it is, patients and clinical input is at the same level. So you are at the same level as the clinical input. Patients and clinical input is one level, and all the methodology and the sort of regulatory and HTA work, that is alongside with that. So the clinical evidence that is being considered is done by methodologists, but the clinical and patient input comes at the same level. So you are at the same level of that. This is, as I've said, this is the split, and you can see that you have had a few patients, 1, 2, depending on the JCAs, and then there's 4 patients and carers for one of the particular complicated cases, I would say. So there is, and they are actually wanting to increase that, and it does depend a little bit on the indication. And I have to say, at the European level, they're also learning through the process. The implementation is now a year in, and they have learned a lot from the first joint assessment to the 14th one they're doing now, that they started this year. So they are learning, and they really are actually understanding the better value you guys bring to the table. So this is sort of the key input that you get from the JCAs from the clinical experts, professional profile, clinical needs, efficacy and safety from their perspective, therapeutic sequence, where does the new treatment fit in, response to discontinuation, practical implementation in terms of the infrastructure, monitoring, how does it work in the sort of health system that we live in, and potential barriers to that, and then some special questions of some key messages and targets that they have for the assessment team. And then for patients, this is really the impact of the disease. So apart from the formal quality of life and the clinical evidence that is going to come in, they are asking conditions of affecting daily life, work, economy, psychological well-being. So the things that you are now collecting and getting ready for DIVA will really be able to directly you will be able to input into that. The current experience with the treatments, the managing your therapies and systems and the burden, patient priorities. I mean, this is huge, really. They want to know what are your priorities, do you want to see in the new treatments, and what do you think will really improve your life? And then the potential advantages and concerns you have from your perspective. And then there's a separate specific area for caregivers input as well. So this is the kind of things, and I should say they are actually, before I move to devices, they are working now to finalize this is the joint clinical assessment questionnaires, but they're working now to develop the joint scientific consultation, the scientific advice questionnaires, and I think they will be ready in April publicly, but maybe I'm wrong, but I think soon is the thing. And there again, that is really a huge opportunity for you to bring in your information. Now, as I mentioned, devices are already in scope, so this is class 3 implantable ones, 2B active devices that intend to administer or remove medicines, or class D, that is in vitro diagnostic devices. And then there's an expert panel on these, and then there's selected, and there's an article that describes it, but in specific areas, in the areas they are identifying, because there are too many devices coming through, so they will have to do a selection of what they deem as important and high risk. So high unmet need, first in class is something new coming, potential impact on patients, so this is again very much important, public health and healthcare systems. There's a huge cross-border dimension, so it is important across all the different countries of the Union, and there will be really seen as an added value across all countries. And then there is a special interest in the ones with AI, as we know, because there are a lot of digital tools and devices coming with AI, and there's an interest for the European countries to, instead of trying to tackle it alone, to try and do this together. So there's some joint understanding around it. And they're going to make the selection of which ones they will look at a quarterly basis. For joint scientific consultations, they had also put some out last year, but no developer came forward. This year they've already received some submissions, and they will have a small group of people from the different subgroups to look into it. So you will have representation from the different countries, looking through that criteria and making a decision. It will also go to the stakeholder network, so patients will have an input there. But also at the national level, and you saw some of the timelines are really tight from Louisa. I'm just also looking at time, I'm on time, I think. That you will not have that much time, so you need to have your information ready. So whether it's the national coordination group member from your country that comes asking for information, or at the EU level, you're ready for it. And I just wanted to end with, there's a lot that we need really from patients, and you really can be the driver of it, and I think with DIVA you are, to create this real world evidence and have real experiences and patient reported outcomes by yourself, where you are owning it, and it's your response, you're working with to create the data you want, you know it, your condition the best, and I think that will really actually enhance the system, and I think finally HTA is ready at the European level to take it on board. Thank you for that.
And now we give the floor to Roberto Saldagna. After this set of presentations, we will leave a few minutes for questions if you have any before starting the panel presentation. So, Roberto, the floor is yours.
Thank you. Well, we have been now seeing the theory, but what is happening in the real world? Because all of the presentation have been addressing the same topic, how we are going to implement a new framework in Europe to address the assessment of the value of the new drugs in comparison, that is HTA, with others that are in the market. The problem was that drugs are not in the market. Not all of them, or not in every country. Or even if we are lucky and we have the drugs, they have restrictions, and we are not using according to how they got the indication at the European level. But here the question is, how we prove that we need those drugs in our country being used in clinical practice? Some trends, it's amazing that this simple question is so difficult to answer from the patient perspective. Because of course we have been working a lot describing IBD, the impact in our daily life, but we have been always describing this information in general, not according to solve STA questions that are more specific and they need to be more accurate based on data. If we want to compare the information we want collecting, gathering from our communities, with those one collecting in randomized clinical trials that are the gold standard, they are going to be the gold standard for maybe forever. So how we need to compare what patients say with that information? The solution is this framework where we are going to be. But what's the problem? The first one is that the national level is going to be involved in the very early stage, defining the PICO. But we need to work at the national level in all the countries with the same approach. Who we are, what drugs are we using, how was our diagnosis, there was a delay on it. Are the current drugs working for us in every of the countries? Are there differences between men, women, according to the time that we have been living with the condition, according to the therapeutic lines? Every time that we go further, it's harder to answer these questions. And this is the information we need. The other problem, practical problem, implementing this strategy is we have been maybe establishing the mechanisms in the public administration to work together for starting the first joint clinical assessment. But the patient participation is still for defining. A simple question. I have been participating in two debates in last month in the European Commission. Only one question and turn down the strategy. What's happening if two patients want to participate in the PICO process? Which one we should select? There is no answer right now. So maybe the STA process is going to start for us officially, if nothing happened before, in 2030. But we are defining now with the national governments and the European Commission how we want to participate, because the current proposal is a minimal proposal. It's just getting feedback from a single patient. In those two events I have been participating in the European Commission transversal debate, patients were claiming that is not enough to include only one perspective from one patient, because it's unfair. What happens if we are asking the wrong patient to answer a specific answer? One of the patients in those meetings were saying that for metastatic breast cancer, invited a breast cancer patient without metastasis. For her was everything fine because she already got drugs that work for her. So if we don't define properly the scope, we are going to miss everything because the assessment is not going to be valuable for us. The idea of this process is to make an accurate assessment so that we can be practical after the process and start with the negotiation of the drug at the national level and start to use the drug as soon as possible if we can prove that the drug is needed because it's addressing an unmet need. What we have been for preparing ourselves, our community, to be ready to participate. The first things we did a few years ago just was build our first version of DIVA to explore the clinical trials around the world and be able to get a big picture of what is the pipeline. Because how we can prepare the information we need to participate in assessment if we don't know the drugs that are coming, or when, with forecasting, when they are going to be maybe in the market or under the assessment. We were working on the pipeline. We were there knowing that according to the drugs we maybe were lack of information. We started to build another model for DIVA to explore the literature. What we know about targeted population. It's not the same. Teenagers with IBD in a specific subcondition that IBD in general. Sometimes we don't have enough information about our patients. So we started to consult the available information in the literature. We started to also, and that was the next step, to ask our community, our patient representative, our delegates, to know what they have about that topic. Sometimes they got an answer, sometimes they say, we don't know. It's not possible to know everything. Sometimes for the assessment of a new biological product is easy. But one of the projects we have is to understand how people are going to react to a preventive drugs. Are we going to use preventive drugs? For how long? What is the side effect we are going to assume if we don't have even symptoms? Or when there is something promising that can change the way we understand even the impact of the disease, fibrosis. Until now we didn't realize that it was possible to think about how wonderful it will be not having fibrosis or reverse the effect of the fibrosis. So we need to keep updating our databases. And this is what we have been working now, going beyond our own knowledge and asking patients, real patients, to preserve their testimony first because there is a bias. I'm here because I can be here. I'm good enough, healthy speaking, for being here. But others can go out of their beds. They can travel. Maybe they are not going to be alive next month. How we can gather those testimonies, preserve them to be accurate enough in every assessment. And that was the proposal of this qualitative study by data saturation, in where we can now break down the patient journey by subgroup of patients, according to what the STA bodies and also regulatory agencies are expecting from us. They wanted the patient journey break it down by sex. Okay, we have it. They wanted according to the drug we have been using, according to the side effect we were experiencing, according to the reason why we quit our past treatments. because they want to know how we make the trade-off, the benefit-risk trade-off. Here we have the information, and now we can share it with them, being reliable. The first country, we have been collecting this kind of information following the methodology that Luisa introduced before with this UNETA 21 pilot questionnaire. The result, after now we have around 50 interviews. We know properly about the diagnosis, but no that there is a late diagnosis. We can't do anything with that information if we don't know the reason of why patients are not getting a proper diagnosis in time. We know what kind of intestinal infections are misleading the diabetes diagnosis. So we can now prepare campaigns for training patient and also physician to be aware of when to maybe start asking again. We know what kind of diagnosis they are, with the diagnosis they are failing, the diabetes diagnosis. We know the access barriers, but according to so many variables, like economical reasons, people don't, in Mexico in this case, people don't, not all of them are able to get access to the free care. Others need to go to the private sector. They need to quit their jobs for getting other jobs that even maybe are not going to offer the same salary, but that at least they are going to get the insurance for getting the drugs. And how this is going to also impact their mental status. Not just is the physical part, the impact of the condition, how we are going to deal with those symptoms, the initial, but also the permanent symptoms. We are detecting how we are undertreated. Because the doses they are referring to us in these testimonies they are low. The frequency, the doses, the treatment. We are now able to break down the information according to even using drugs, the better ones, because they exist in Mexico, they still have persistent symptoms, and we know which one are they. And now we can say that fatigue, the abdominal pain, the urgency, for who specifically is the problem. And how, of course, how this is transforming the life in the IBD patients in Mexico. And this kind of information is what the everybody wants to hear. Because if we can tell them how a new drug, in comparison with others, can change your life meaningfully, we can justify the use of the new drugs for those kind of patients. But first we need to identify this. If we can go out of house, if we can keep working, if we can avoid surgeries, because surgery is not the problem, it's what happens after the surgery. When we can justify everything, the conversation is smooth. And the fact is that I have been working in STA for many years. Now, thanks for working with data, I have been the only patient nominated in my country for being part of the adopting commission to understand why we are not using the innovation in the country. Because we know that sometimes we are not making the best solutions. We are more focusing on the economic impact of the innovation. We are not ready because of many reasons. Maybe the professionals don't have the proper facilities to implement the innovation, or they don't have the knowledge. We need to understand that. It's not only to explore the horizon scanning, to make a good assessment. We also need to understand the barriers that are impacting the adoption of the innovation. Because for us, this is what is really important. Maybe we are focusing on temporary symptoms, diarrhea, urgency, but the impact of the condition affects us for life, our life, forever. Every time that we are earning our salary every month, we need to remember that it's going to be lower than other people without the condition. And this is a reality. We are doing more, making a big effort to get less than the others. And this is frustrating, this is exhausting, and this is what is explaining why the 21% of the patients are dealing with suicidal thoughts. That is also gathered in the testimonies qualitative studies. Another question is, are we happy with the unmet needs definition that the public administration are using? Until now, unmet needs is just like something, if we can treat properly the condition with the current drugs. If there are drugs and we can treat the condition properly or satisfactorily speaking, it's okay. But according to what we have been collecting from our communities, will we say that we are right now treating properly or satisfactorily? I believe. See, if the answer is no, maybe we should work on a new definition of unmet need and propose ours. I know that all the stakeholders have one, but it's time to start work together to see how we can address this. If we really want to help and support those patients who are really suffering. Because when we started to say the psychological impact of the condition, we realized that, of course, and it's always good to have a psychological support. But if people is suffering because the effects of the IBD condition are permanent, and maybe because the condition for certain patients and the drugs they are using are not good enough, and we need to keep researching, we need to keep investing on innovation, and we need to justify highlighting that if we are suffering, it's because not everything is okay. And it's the same with how we are going to demonstrate unmet needs. Randomized clinical trials are going to be the standard. We need to include those outcomes during the trials if we want them to listen to us as soon as possible. If not, everything is going to be a negotiation. Because the patient perspective right now is for contextualize the debate. It's not for just giving us the reason and introduce the drug or to discuss how good it is. No, it's for contextualize the debate, to analyze the data, the best data we can have. So, if we can collaborate all together to define the best outcome from the patient perspective, to include it during the trials, it will be ideal. Not all of them are going to be included because it's not possible, but at least the most impactful one. And now we can see an example of how we are working, because every time that the public administration is asking us something, it's just as I said before, we need to consult the information we have internally in our organization, to analyze it with our expert delegated, and if no, we don't have a clear answer, we need to explore, generate more material, generate more interviews, generate more surveys, and once we have an answer, we can send our feedback. If not, we are going to say, we are sorry, but we don't have enough information, and it's a pity, because it happened in the past. When there is a controversial issue with a drug, with something that is affecting us, and we can only say we don't have information. That's it why it's so important for us that we all work on this approach, generating and keep working on the evidence we need. And it's something that we can scale up. It's so easy, it's open source, it's multilingual. All the information, even the testimonial that we have been recording in Mexico, can be read in any language in Europe. Because sometimes, and we did it this way because sometimes, for exploring everything in general, it's okay. With one country, one language is okay. But we are going to analyze a subgroup of patients very specific. It's possible that only few patients are going to be in Spain, others in Germany, others in Finland, and if we don't merge the information, maybe we are not going to have a good answer, because the sample is not going to be enough. So we are going to keep working on it. We are going to scale up. The idea is to share it with all the stakeholders, because, and this is something I have been working with at my national level. With drugs, maybe it's going to be challenging. We are just learning with the device. Do you know how many devices are there? 4,000, just for waiting for the assessment. If we know automatize the process, it's going to be possible. So we need to share these technologies with all the stakeholders that are interested in explore what patients say in an automatic way, in a proactive way, so that we can still realizing if there is something missing, and so that we can work on that. And that's all.
Thanks, Roberto. As I promised, if you have any burning questions, this is the right moment to raise your hands. In the meantime, our colleagues will put the chairs for the panels, so we need a couple of minutes for organizational solutions, let's say. But if you have any questions regarding the previous presentation, please feel free to do it now. Thanks.
Roberto, that was an excellent. Oh, thank you. That was an excellent presentation, and congratulations on all the work that you're doing with DIVA. Question for you though, how flexible is DIVA in adding country-specific questions? Are you able, for instance, if the US were to join DIVA, to add questions related to our insurance?
Yeah, it depends on the organization. DIVA is now prepared. Just you have an interview, you record it. DIVA now transcribe it, categorize all the information according to the variables we are interested in. Others, we can explore it with these tools that, because you can keep talking to the patients after that, thanks to the artificial intelligence, but it has been automatized. It depends on you, how fast are you to collect more interviews. DIVA can do it in minutes.
Thank you, Roberto, for this great talk. I just wanted to know, you said interviews. Can you elaborate a little bit on what you are asking there and how long all those interviews are? Yeah,
the interview is the official questionnaire from the European Commission, the one Luisa's presentation had. Is a public questionnaire, and it includes around 17 questions. What symptoms do you have? What diagnosis? How you started with the condition? What symptoms led you to the physician? what was his or her first reaction, what was the first treatment, how was the expectation, and if you met the expectation, what was missing, because maybe a drug can work, but for certain symptoms, not for the others. If they had side effects, which one were the worst? So with those answers, we can start preparing something like Excel with all the variables, all the symptoms, all the drugs that they have been using, and also everything they are speaking about them in an emotive way. When someone says a drug changed my life, we can also capture that it's positive. On the contrary, I don't want a drug because I'm afraid of the side effects, or I can afford it. So we can classify that like a economical barrier for accessing to the treatment. The questionnaire is official. It's the official one. And an interview, depending on the person, lasts around 1 hour.
Thank you for a lovely talk. This is very exciting. This is probably beyond the scope of this meeting, but do you have technical documentation regarding the AI, how the model is trained, data security, things like that we could access?
Yes. This is more complex. There is a framework in Europe for building this kind of register. We are following the official one.
Do you have something documented you could point us to on your website, or that we could read through to understand?
We haven't published it, but it's, we can do it because all of this is free software, free methodology, so we can share it.
Yeah, that would be great, because I think a lot of people are concerned about AI and security and things like that, and so for patients to be open and honest in the platform.
Everything is anonymous. It's anonymous because the name of the person is not relevant here. What is really important is the history. We don't store any data information, only the transcription without any names. Not the person name, but also if they are naming a physician during the call, we also remove the name of the physicians, just for being sure that we don't need to pointing out anyone unnecessarily. But there is we have a consenting form before the calls. We have everything very well documented and explained it. Yep.
Thank you, Roberto. Very interesting. Just have a very quick question. So, how many patient testimonies have you collected so far, and maybe what's the goal next year?
We have started in Mexico. Now Costa Rica is also joining. Greece that has started already. Italy is the next country. We have the conversation with Denmark, and that I hope that it could be soon with us. We are open. Of course, we are just a few team. We need to prioritize the order of the countries, but the idea is to be in as many countries as we can. For us, this is the priority, because it can make changes.
I think we need to ask if there is any further super burning question, but it has to burn a lot. If not, I would move to the panel presentations, so then we also have the time to present our case study. Roberto, don't move because you are the first one. And may I ask the other panelists to sit on stage? Vaso from Greece, Beatrice from Mexico, and this is another, I think it's important also to focus on practical examples, because we have been working a lot on the theoretic side, but now we are really pleased to have the opportunity to present what we are doing concretely in some of our countries, bearing in mind that these are 3 pilot experiences, but we are already working with other countries. We mentioned Italy, we are working with Denmark, and I think the most fascinating aspect that depending on countries, even thinking to your question, Laura, we really need to take into consideration the different environments or contexts, you know? And every time is a new challenge, every time there is something new that we are learning, but I think this is the added value and the high impact that DIVA can offer, because we have the flexibility and the capacity of adapting the system, because we realize when we talk about patients, conditions, we can't be rigid, we need to be flexible, because we need to listen to people to understand what they need, and this is part of the journey and the challenge. I also introduce myself, Taran will be the moderator, and I will ask Roberto to make his presentation. It's as you prefer, you can stay on the podium or you can sit there, it's up to you. I'm not threatening you. You can.
I can be here.
Okay. Sorry. Go.
Okay. Sorry. I'm still sleeping. No, my experience in Spain. I have been working with my national government for 10 years. Spain was one of the most advanced countries incorporating the patient perspective. It doesn't mean that it's perfect, because until now, the last, even now is in parallel, the new approach with the last one. We have been trained by the National Agency about what they were, not just what is the process, but also about what they are expecting from us. But because that was the most challenging part. When we selected for DIVA this official questionnaire, it's because we have been speaking with them, clarifying the expectation. They were the ones suggesting to us to use this questionnaire for collecting information. So they have been always proactive, supporting the patient organizations. Now that we are updating the regulation to implement the European new framework, we are defining the new legislation according also to our way to understand patient participation. We have been defining who are the stakeholders, what kind of patient organization can participate, what kind of profiles should be the ideal to participate in these kind of things, because we are speaking about patient organization in general, patient representative, but none of us are doing the same. I'm more practical, theoretic at the European level, but others are doing a great job supporting patients face to face, and they need to keep doing it. But of course, if we expect them that they haven't even known what is HTA, maybe the consultation is not going to be successful. And this is one of the problems we try to solve in Spain. 60% of the patient organization, even when we get the drafts of the assessments, we don't answer. And we don't send feedback. And this is a problem. Because we need to understand if, first, it is because we know that maybe sending feedback is not useful. Maybe because we don't feel comfortable speaking about technical issues that other patient organizations already said. I can't read a dossier. I don't know what to say about the benefit-risk assessment. I don't know if what you want from me. So we started with those roundtable to close the stakeholders, to improve the relationships, the expectation from each other. And now we can say that everything is under the patient perspective. And this is great. They have been included not only because STAs, we saw several subgroups of working groups. The horizon scan is important. the joint scientific assessment, consultation, is even more important. The joint clinical assessment is just the last part of the process. If we can work together in advance to provide better feedback to the sponsor, to understand the result of the clinical trials with the same perspective, it's going to be easier for us, it's going to be faster, and everything is going to be better. And this is how we have been working now. Even we changed the legislation for patient organizations to recognize that it's mandatory to include the patient perspective, not only in STA but in everything. I can't complain. They included all my feedback. Well, I could say that for the debate, the devices, they are asking the patient organization in Spain to make a pilot like the one we are doing in DIVA, because it is positive for them, the feedback we are going to share with them, even they are allowed to open the budget for the patient organization to keep moving to this new kind of expertise, because that was the other challenge, to find the proper people in a patient organization with this technical knowledge. But the public administration, according with this pilot, is going to be also able to get funds for the organization thanks to this collaboration.
So now, thanks, Roberto. I steal the microphone, so for the next panelist, I kindly ask you to use the other one. I just want to put a question mark for the next part of the discussion, because I think that what you are mentioning regarding the fact that the public administration is thinking to open a budget line to support this kind of expertise, let's say, my question is, but it's going to be for the next, for the round of the panelists, what do we do with conflict of interest? That I think is a big, heavy something. I don't want to open now the Pandora box, but I think that since the audience is made by patient associations that are involved also with the industry, and not only, this is going to be, I think, another big challenge for the coming years, because we really need to, again, to join forces and define the issue, because if not, we are going to be like a hamster in a wheel. We are not able to find solutions, and we need to find solutions very quickly. But it's for after. Thanks. And now it's my pleasure to present the Greek experience. Thank you, Vaso.
Good morning, everyone, and thank you, Lisa. Thank you, everybody, for joining us. It's a great honor to represent the Greek pilot, in which we had the honor to work closely with Dr. Tarang Sharma, and it was really good as an experience. Until very recently, patient involvement were not systematically integrated into HTA in Greece, and in many countries as well. There was no clear legislative framework defining how patients and how patients' representatives could contribute to HTA processes and joint clinical assessment, etc. Assessment, we see the unseen. The assessment affecting access to medicine and health technologies were conducted without structured patient input, without those that they need them. Recognizing this gap, Greek authorities initiated the reform process to strengthen the national HTA in close collaboration again with WHO and the Europe office. And a core objective of this reform was to embed meaningful stakeholder engagement and patient representatives specifically. Patient participation is increasingly recognized as essential, and now we are in every panel discussion about HTA, and thanks to all of the Greek Ministry of Health, the WHO and other stakeholders involved in this reform. And patient representatives are now included at the strategic decision-making level. You know that the national umbrella patient organization in Greece, the Greek Patient Association, is recognized formally by the state as the official interlocutor for health policy in Greece. So, thus, this inclusion shines something very specific. Shines the growing institutional recognition of patients as equal partners in health policy. I don't know if we feel how important is this for patients and Greek patients and all the patients, not only in Europe, but internationally. We have the patient at the center of decision making. A few weeks ago, we ran the first pilot implementation of patient involvement in HTA in Greece. It was something new. It was the first time that for this pilot, the Greek Ministry of Health formally requested by the umbrella organization to delegate patient representative. It was a medicine for breast cancer, so two patient representatives for the oncology therapeutic area participated in this pilot assessment, and this was the first time, is marked as the first time, patient participation was formally incorporated into HTA in Greece, and of course this is a milestone for Greece. This pilot was a milestone and also a moment that we ran an exercise both for the institutions, but also for the patient representatives, how it works, how we collaborate effectively, and how all of these topics can be in the center of decision making, and how can powerfully and meaningfully change the patient participation in HTA. Closing this first presentation with saying that although patient involvement in Greece in HTA is still at a very early stage, the current reform process provides a very strong foundation for better outcomes, for better participation, for better inclusivity of patient representatives. And of course, we thank all of the stakeholders in Greece for making this not only a dream, but a reality. And this is very vital, and I hope that we will remain at the same level and even more and more. And I hope also other countries take some, let's say, good practices from this pilot and integrate also patient participation into their HTA process, but not only in HTA, but every process that needs to be done. Patient should be at the center of the decision making. Thank you so much.
Thank you, Lord. Do you have any quick reactions, or I can pass the floor to Beatrice from Mexico? I'm particularly pleased because 2 years ago we started your journey. There are some friends that were there, and in less than 2 years, I'm pleased that you have the chance to see what we have been. Beatrice and the Patient Association in the area has been able to do in less than 2 years, thanks to DIVA, but also thanks to the great motivation they have. So, please, Beatrice.
Well, thank you. Hello. I'm here representing the voice of Mexican patients, or the voice of persons with IBD, and in fact, I'm one of them. So that's why this project starts, because for over 12 years I have listened directly to people living with IBD. I have read hundreds of emails, testimonies, WhatsApp messages. I have taken part in more than 100 support groups and held countless conversations with persons. What I kept hearing was not only a need to be listened to, but deeper request. They really want that their experience be useful for another patient. So they want that, make it count. Their experience, their suffering, want to be for something. They want to add value for, say, decirlo así, this is why I began this project. I want to take what had been subjective, fragmented, and invisible, and take it and turn it into something objectable and actionable. By integrating patient interviews and analyze them with AI, We found a way to transform individual experiences into hard data that can help us to make informed decisions. Mexico matters because it reflects many of the challenges it has Latin America, late diagnosis, unequal access, and life decision shapes not by choice, rather it's by health systems. In other words, my objective, I can say that word, objective. My objective was to turn years of listening into evidence that hopefully can change systems. Let me read two stories. Roberto sets the numbers, but I will tell you the stories behind the numbers. That really matters. Last week, it really happens last week. Let me share the story of Eder, a 16-year-old boy diagnosed with fistulizing Crohn's disease. His father contacted us, our association, seeking information. Eder was treated in a private clinic and prescribed just 1 dose of adalimumab, but his family couldn't afford the treatment. So he was referred to the public system. There, he was hospitalized several times, but the treatment was denied because doctors claimed it was not Crohn's disease. Despite lab tests and biopsies, he was treated only with enemas. His condition worsened and tragical, he passed away last week. And this is not an isolation case. Another patient with the same diagnosis, fistulizing Crohn, is still trapped in the system. Repeat hospitalization, loss of jobs, ongoing doubts. Although specialists confirm fistulizing Crohn's disease, the public clinic questions the diagnosis because his calprotectin is not above 2,000. I heard his frustration, even expressed with laughter and sarcasm. Apparently, Crohn's disease now is diagnosed only by a number. This is still happening, and its unfortunate consequences. 83% of late diagnosis, 66% of cases were misdiagnosed, gastritis, parasitus, IBS, nevus colitis, hemorrhoids. 75% fake success barriers such as cost, distance, bureaucracy, lack of medicines. Despite treatment, 58% report persistent symptoms, fatigue, pain, urgency. Health systems often assume that once treatment exists, the problem is solved. The disease reshaped the decisions. Here's another story. The case of a young psychologist who is unable to work independently. Due to her disease, she needs health insurance to cover the medicines, so she now works as a school custodian, only to have access to Social Security. So 95% say their lives have been changed. They suffer from social isolation, loss of jobs, and loss of dignity. Many decisions are life-changing: career paths, having children, personal relationships. Women face a triple burden: economic, psychological, and caregiving. That is part of Mexico shows patient experience can be structured and analyzed. AI does not replace patient voices. It only organizes, protects, and amplifies them. Each and every story matters, and together we can change, or we hopefully change the system. And that's it.
Thanks, Beatrix. I would work, I'm pretty sure you have some questions. I would start with the questions from the floor, and then I have a couple of questions. I'm sure you also have them. So, do you have any questions? Are you awake, please? I don't see anything. need an umbrella. Do you have any questions? So, if there is no question, I start with a very, don't be scared, it's an easy question. I think that we had the chance really to listen to different experiences and also different level of... Where is the umbrella? Okay, thanks.
My question is just how do we reach all the patients? I mean, there are some hurdles. I think for one, not everyone is in an organization. Then if you have the patient, you also need a competent patient who knows terminology, who knows a bit about the sickness. And yeah, in so many cases it's not clear, is a side effect from this drug, is it from this drug, is it from one health condition? A lot of us have multiple conditions. Yeah, how do we differentiate and how do we clear the data or organize the data for this?
We only need to capture the information. And we are going to share the information with the expert, the steering body, the medical society, with other people who are going to help us to analyze the information. In the same way, we are already participating in pharmacovigilance. We don't need to make the link between the side effect and the outcome we are getting from those side effects. No, our job is just telling them this is happening. Now, tell me, there is a connection or not. But it is simple. So we don't need to complicate it. It's just hard. What we are doing, don't complicate it.
Okay, thank you.
Yeah, this is the IFCCA side. I just wanted to add to the first part of your question. Of course, we are not able to intercept all the patients because not every patient is part of a national association, for instance. But what we can do, and we are already doing, is offer training and education for those, of course, that are willing to do it. That is very, very important because you need to build on a certain level of expertise. Because as Roberto, but also Vaso, were saying, very often you have to deal with papers, documents, instructions that are very difficult to understand and to digest, if you allow me, connection with IBD. And this is part of the journey, because we need to train and we need to educate patients and all those who are willing really to try to change since the beginning the journey. And of course, there is a need to invest on it, but I have to say that it works. I mean, it's a long journey. I'm not saying that we have all the solutions or we solved all the pending issues, but it works. So it really depends on how we can work together and join forces, and then we will be able to find a way, I think.
Regarding that, anyone is able to participate and give up the history. So maybe in the future we can also collaborate with the IBD nurse that are in touch with the patient, with the medical society, with anyone who want to participate and keep working on this patient register, because it is going to be useful. And people, when we are promoting what we want to do, they are really interested in participating. We have facilitated, because people are fed up of questionnaires, but people want to be heard. And in an interview by phone is so easy for them, and they are really eager to participate. And this is our experience.
Thank you very much for the. I'm over here. Thank you very much for the presentations, and I think it's my first day here is a perfect way to start my ECCO experiences, reaching the patient. So my question is, if I think about every patient's journey, it's almost like if you look at a graph, it's like a line through from pre-diagnosis all the way through the experience of changing therapies and dose changes and things like that. Is there any way that you'll be able to ask patients to put multiple submissions in of their experience as they go through their journey with IBD, so you can almost see how that changes over time, and the differences between different patients' experiences. Always like different coloured lines on a graph, and it's different experiences.
It could be great over time. Now we are doing it through this course study, but one of the things that we can do with this information is to keep understanding it. Open the consultation to other patients, to other stakeholders, so that we all can add our comments. Because this is the data, but just as I mentioned before, now the data need to be interpreted and even complemented with other visions. Oh, there is a question there?
Thank you so much, Roberto, and yeah, the whole panel for this super interesting session. I have a question in terms of implementing those frameworks into the different countries, or assessing basically with your questions and the tools. What are the challenges that you meet? What are the most the critical challenges in different countries, and in which country would you say is the most troublesome in terms of getting access to the patients and also appropriate answers, and then also which one is the easiest one currently?
I think that every patient organization has a good database, a very good community. Getting access to patients for participating in this kind of programs is not the problem. The problem maybe has been at the very beginning with all the documentation we have been filling and writing. For example, the request framework, that's one I mentioned before, to define how we are going to protect the data, how we are going to explain the recruitment, the criteria, everything. Maybe in some countries it's possible we need to change it and adapt it because the local legislation can be slightly different. Not very much, but slightly different. Or maybe we need to go through an ethics committee because we are building a register of patients. It's dependent, but the bureaucratic part is always the most challenging one.
And which countries would you say ultimately is also the most country, or the most challenging country, and the easiest country maybe, with the lowest barriers in terms of implementing this framework? Do you think?
Yeah, we are not mentioning any country. We are working with all the countries, and we are not mentioning any specific easy or difficult country. It's not up to us to have a list of those who are more, how can I say, compliant or not. It's not our business, and we will never give such an answer to anyone. We are working with everyone. So.
Yeah, I just was curious about the different, the challenges that you meet along the way.
The challenges may vary from one country to another one. In some countries you have some challenges, in some other challenges.
Maybe the challenges are the resources that maybe the patient organization can have, if they have the technician, if not, because even to have someone making the phone calls is enough to start the program in their countries. But if they are just volunteers without any I don't know, I don't want to say any time. It's going to be difficult. They need support to maybe hire someone to make the calls, or maybe they need some analytics, statistics for just interpret the results at the local level with the meeting they are organizing with the public administration after the failure reports. But it's going to be something we need to discuss one by one, because every country, every organization have their own reality.
Absolutely, thank you so much.
Then I try that. I think, obviously I know the Greek experience really well, but it was really nice to hear what is happening in other countries and the information you shared from Spain, and you can see that you have a great history of involving patients, and you're very much at the start of doing that in Greece. And your story in Mexico and what you're doing is really, really powerful. I mean, really powerful. How do you think you, all of you, can now take from these short pilot projects or these initial experiences to sort of scale up and expand, and what do you think would be the next step for your own countries?
Okay, I can start. I think that it should be mentioned as mandatory for, the main problem in Greece was that every time the minister changes, maybe he or she wants to change everything. That was the big problem in Greece, so we have to face it and we have to make sure that even if you are the Minister of Health or you are, it will be remain mandatory for the patient representatives to be included at the center of decision making, in HTA specifically and in general. Because the pilot project was a milestone, but it can remain only a milestone if we do not go further. So that's the main challenge we have to face in Greece.
I know, I say also that not all the barriers are from the patient association perspective or are our barriers. The public administration don't have enough human resources for doing this. And they don't even have the budget to hire the human resources. And this is one of the main issues they were raising in the two meetings I was last month. They don't have people. So how we are going to do this with those agencies where there isn't personnel? That is going to be challenging. The good thing is, at least now we are more prepared. Maybe one of the reasons patients didn't participate in past consultation was that it was so difficult to read a document to find what is not written in it. When the draft of the assessment describes the disease, maybe you can say it's okay. But there is maybe the most important symptom is missing. And you are not training to look for what is missing. Nobody told you that. There isn't any instruction. They send you this, the draft by email and say you, what do you think? So it's so difficult to participate in it. And this is because of the lack of human resources. They don't have time and people. Now we are just changing that. Maybe in a few years it could be easier to participate. But it's not just because they don't want us to be involved, it's because they don't even have the time to check if the email registered a few years ago to participate in this kind of consultation is still the right one that the organization is using. That is happening.
You wanted to say something about your experience?
Well, in Mexico, our problem today is that HTA process is not taken in account. So we have a lot of patients eager to participate, but the government, or not the government, the stakeholder, the decision makers don't want to know. They don't want to know our experience because they have to record it, and they don't. If you have numbers, you have to work with that numbers. It's easier for them not to have the numbers because we don't know. So that's, I think, the biggest problem.
Any other questions? We still have 5 minutes before you wrap up or before we close. If you have any other questions, if not, I have a question for the three panelists that is very much connected to what Taran was asking them, but I give the priority to the audience if you have any other questions. Nobody. So it's an easy one if you want, and I think it could be also seen as a kind of conclusion from your side. Which kind of recommendation? Because we have been presenting today the methodology, some practical exercises or activities that we are developing, but we are also asking all patient associations, our members, but also not necessarily only our members, to work with us, to define with us which are the next steps, and to really let's help each other to collect as many accurate information as possible. So my question is, based on what you have been already doing in your country, which kind of recommendation or tips you would share with the other associations that would like to start working in this way? Because I think that again, there is a transition from the declaration of intent that is, okay, I don't know, whatever count, I'm Venus, and Venus wants to involve patients. And then which are your practical suggestions? Which have been the positive aspect, and which have been the obstacles or the difficulties? Because I think it's important to share also this general picture in 1 minute each, because then we need to close.
Well, my advice will be, if the interviews are made by patients, they are really more rich, because it's the way you express with another people that suffer the same is richer than if someone else that doesn't know the disease want to do the interview. So if you have volunteers in your team, they can make the interviews, and they are very emotional. If you heard a lot of people telling their story, it's very, sometimes you cry, sometimes you laugh with them, sometimes it's very impressive how they want to participate to being helpful for another person.
First of all, don't afraid to ask. There's no silly questions, and the next one is to be open and share experiences with other patient associations from other countries, and maybe why not to ask also for a mentoring. If a patient association has more experience than your association, you can ask for mentoring from this association, and I'm sure that every patient association in every country will help another patient association in another country to make it this work.
Okay, I will say that we are here to support all of you. That is a good takeaway, because if you have any doubt, you can call us. But I also have a takeaway for the industry. You are here. We also need to change the way we are collaborating, because many companies are not collaborating with our national members until you get the indications. But we saw that we need to start collecting the evidence and participating in the PICOs before you get the indication. In many countries, the only way that patient organizations have to participate is with your resources. And we need you also. We can do it together. But if we are late, we are not going to be able to send our feedback. That is a reflection.
Just to sort of hear and put from our perspective as a person who's been working with evidence for making decisions and supporting countries to use evidence to inform their decisions. If you don't provide the actual evidence at the right time, you'll be missing a very core part of input. So you need the right evidence at the right time to actually impact and influence policy and decisions. So it's really important that you collect the information and make it available and accessible at the right time for those decisions.
Well, last call for any comment. We need to leave the room because there is other meetings booked for this room. Do you have any final thoughts you want to share? Okay, so it's finished. It was great. It was emotional. It was important. It's another step towards a journey that we want you all be involved. See you very soon with another piece of our work. It was great. Thanks a lot. And enjoy the ECCO Congress, and thanks to ECCO that gave us the opportunity, and thanks to the panelists, and thanks to the board, and thanks to everyone. And Salvo, come and say something, please, our chairman.
I would just express everything with a word. I would say gratitude for excellent quality of the speakers. I want to be very thankful for the work of the staff that created this. Let me express a personal thank you for the patient organization who joined this meeting. Many of them are volunteers, are patients. They leave their family and they joined this meeting for a couple hours, especially with a time that the schedule was not perfect for traveling. And thank you all for joining us today and being here with us and share what we think about the management of the disease. So thank you so much.